Welcome, viewers, to another intriguing exploration into the world of pharmacokinetics. Today, we're delving into the captivating realms of linear and nonlinear pharmacokinetics, unraveling the complexities that govern drug absorption, distribution, metabolism, and elimination. First of all, I introduce myself. I am Dr.S.Jegenath, Associate Professor, Department of Pharmaceutics, School of Pharmaceutical Science, Vels University. In this module, we are discuss about Introduction to Linear Pharmacokinetics, Non-Linear Pharmacokinetics, Detection of Non-Linear Pharmacokinetics, Causes of Non-Linearity, Michaelis-Menten, Enzyme Kinetics, Michaelis-Menten Equation, Estimation of Vmax in Km, Calculation of Km, Vmax study, State concentration, methods used to determine the Km and Vmax at steady state. Okay, now let me get into the topic. Before entering into the topic, we discuss about the linear pharmacokinetics. Linear pharmacokinetics, often considered the conventional route, follows a predictable and proportional relationship between drug dose and concentration. Discover the straightforward patterns that characterize this fascinating aspect of drug metabolism. At therapeutic doses, the change in the amount of drug in the body or the change in its plasma concentration due to absorption, distribution, binding, metabolism, or excretion is proportional to its dose, whether administered as a single dose or as multiple doses. In such situation, the rate processes are said to fall first order or linear kinetics, and all semi-log plots of CV's TE for different doses, when collected for dose administered, are superimposable. The important pharmacokinetic parameters VSDAR, F, K, Ki, VD, CLR, CLH, which describes the time course of adrenaline the body remain unaffected by the dose. Pharmacokinetics is dose independent. So now we cleared about linear pharmacokinetics. Now enter into the nonlinear pharmacokinetics refers to a situation in which the relationship between drug dose and its effects on the body is not proportional. In contrast, the rate process of drugs ADME are depend upon carrier or enzymes that are substrate specific, have definite capacities, and are susceptible to saturation at a high drug concentration. In such CK, so now we discuss the detection of nonlinearity in pharmacokinetics. Detecting nonlinearity in pharmacokinetics is essential for understanding how a drug behaves in the body, especially when the relationship between dose and drug concentration is not proportional. Here are several methods commonly used to identify nonlinear pharmacokinetics: dose proportionality studies, pharmacokinetic modeling, comparison of AUC and COMEX, non-compartmental analyses, examination of dose-response curves, saturation of elimination processes, steady-state considerations, statistical tests. But there are several tests to detect non-linearity in pharmacokinetics, but the simplest ones are first test, second test. First test: determination of steady-state plasma concentration at different doses. Second test: determination of some important pharmacokinetic parameters such as fraction bioavailability, elimination half-life, or total systemic clearance at different doses of drug. Any change in these parameters is indicative to nonlinearity, which are usually constant. Now enter into the causes of nonlinearity. First one, drug absorption. There are three causes. I. Solubility. Dissolution of drug is rate limited. Griseofulvin, at high concentration in intestine. 2. Carrier. Mediated transport system, ascorbic acid, saturation of transport system. 3. Pre-systemic gut wall, hepatic metabolism attains saturation, propranolol. These parameters affected FK, Cmax, and IUC. A decrease in these parameters is observed in former two causes and an increase in latter cause. Second one, drug distribution. At high doses, non-linearity due to two causes. I. Binding sites on plasma proteins get saturated. Phenylbutazone. In both cases, there is increase in plasma drug concentration. Increase in VD only in I. Clearance with high ER get increased due to saturation of binding sites. Third one is drug metabolism. Non-linearity occurs due to capacity-limited metabolism, small changes in dose administration, large variations in plasma concentration at steady state, large intersubject variability. Two IMP causes: I. Capacity, limited metabolism, enzyme and cofactor saturation, phenytoin, alcohol. 2. Enzyme induction, decrease in plasma concentration, carbamazepine, autoinduction in dose-dependent concentration, saturation of enzymes, decrease in CLH, increase in C-cis. In case of enzyme induction, reverse condition. Other reasons include saturation of binding sites, inhibitory effects of the metabolites on the action of enzymes, and final, drug excretion. Two active processes which are saturable. 1. Active tubular secretion, penicillin. G. 2. Active tubular reabsorption, water-soluble vitamins and glucose. Saturation of carrier systems, decrease in renal clearance in case of I and increase in I. Half-life also increases. Other reasons like forced diuresis, change in urine pH, nephrotoxicity, and saturation of binding sites. In case of biliary excretion, non-linearity due to saturation, tetracycline and indomethacin. Here are the examples of drugs showing non-linear pharmacokinetics. GI absorption, saturable transport in gut wall, riboflavin, gabapentin, saturable GI decomposition, penicillin G, omeprazole, intestinal metabolism, propranolol, salicylamide. In distribution, saturable plasma protein binding, phenylbutazone, lidocaine, tissue binding, imipramine. Metabolism, saturable metabolism, phenytoin, salicylic acid, enzyme induction, carbamazepine, metabolite inhibition, diazepam. Renal elimination, active secretion, para, aminohippuric acid, tubular reabsorption, ascorbic acid, riboflavin, change in urine pH, salicylic acid, dextroamphetamine.
Here we completed the basic concepts of nonlinear pharmacokinetics. In next video, we will discuss about the Michaelis-Menten enzyme kinetics.